Thank you so much for joining us today. We are so glad to have you with us for today's conversation, which is the second in a three-part series designed to support Delaware professionals who work with terminally ill adults and others who may be considering their options for care at the end of life. On behalf of the clinicians joining us in this presentation today, as well as the team at Compassion and Choices, I want to start by expressing our thanks for the work that you do and the time that you are taking to learn more about medical aid in dying. Whether you have worked in healthcare or specifically in end-of-life care for many years or are new to the field, the investment in understanding this option and considering how to integrate it into the care you provide is so valuable, and we thank you. Last month, we provided an overview of medical aid in dying, and so today we are going to dive deeper into the multi-step process and navigating a patient's request that is required by the Delaware law. We will be touching on the regulatory requirements, the forms to be completed, as well as the conversations that are an important part of aid in dying care. As we get started, I want to take a moment to highlight a few important points. First, closed captioning is available via the Zoom controls found at the bottom of your screen. Today's session is specifically catered to professionals. We will not be providing medical advice or addressing specific situations, particularly for somebody who might be considering this option for themselves or a loved one. We really are focused today on supporting our colleagues. And our plan is to have a panel conversation, so you'll be able to hear a variety of perspectives. This program is being recorded and will be available on demand. And we are here to share information, but are also here to answer your questions. So additional members of our team will be monitoring the chat. Thank you. And we'll be able to assist with questions that are raised during our time together. And it is our intention to have time for live Q&A at the end as well. And finally, the third webinar in this three-part series will be next month on March the 10th, and we hope that you will join us. And now, today, I am honored to be joined by three amazing clinicians. Each of them not only represent years of expertise and compassion for end-of-life care, they are also just amazing human beings, but they also each represent a different jurisdiction where medical aid in dying has been a part of their practice for a number of years. And so I'd like to give them each an opportunity to introduce themselves. Dr. Barnard?
Thank you, Jessica. I'm so pleased to be here and so grateful that we have people on this call who are interested in learning more. I'm Diana Barnard. I'm a family practice doctor, and I'm also board certified in hospice and palliative medicine. I practice in Vermont, where I was a part of our legislative effort, and I do practice palliative care, and I am a prescriber, and I have also worked with Compassion and Choices to try to assure that this option will eventually be available to everybody in all states across the country.
Thank you. Susan?
Hi, my name is Susan Gess. I'm a pharmacist from California, and I've been doing the consulting role in medical aid in dying since the law went into effect in California since 2016. And what that looked like was bringing the medication to people's homes and having a very personal discussion, not just about what the medications would do, but what it would look like to die and how to support the family. I've supported Compassion and Choices in speaking engagements and in training pharmacists in new states to do this role. And I also serve as a board member and volunteer with End of Life Choices California, whose mission is to provide information and support for people looking at their end-of-life options. So a lot of that would come into play here.
Wonderful. Thank you. And Dr. Richmond.
Hi, thank you. My name is Dr. Sonja Richmond. I am board certified in internal medicine. I am boarded as a hospice medical director. I currently serve as chief medical officer with a nonprofit hospice organization here in Virginia. I'm licensed in DC, Maryland, and Virginia. Washington, D.C. is where I earned my wings, bread and butter, and was part of the launch of medical aid in dying in D.C. I serve primarily as a consulting physician, but I too am a prescriber. I have witnessed patients going through the process, walking with them, and also patients who unfortunately passed away prior to ingesting their medications. I've served with Compassion and Choices proudly and happily over the past 5 years in an advisory role, advocacy role, any opportunity that I can speak about end of life care and options for the people we serve. Thank you.
Wonderful. Thank you all so much. And to properly introduce myself as well, my name is Jessica Empeño, and I have been a medical social worker for over 25 years. I have advanced certification in palliative and hospice care, and have worked in the community here in San Diego, California, supporting people at the end of life, people facing dementia and other serious illnesses. And have been a part of medical aid in dying, both at the bedside, but also in supporting staff and supporting the clinicians who are going out there, developing policy, providing training. And in my role with Compassion and Choices, I am the National Director of Clinical Engagement, which gives me the opportunity to work with amazing clinicians like we have with us today. But really focus, our team is working on making sure that professionals have the support and the resources that they need to support patient-directed care at the end of life. And so we've touched on this already. Each of us is here today because we believe that compassionate and quality patient-directed care at the end of life is essential and something that everyone deserves. Compassion and Choices is the nation's oldest, largest, and most active nonprofit organization working to improve care and expand options for care at the end of life. And we've been doing that for more than 40 years. We have been working to change policy and practice while raising awareness and empowering communities so that everyone can access the information and the care that they desire. So as we get started, we wanted to start with a quick question for you. So a poll will be popping up on your screen here shortly. And if for some reason you're not seeing it or if it's not working for you, please feel free to write your comments in the chat. But we want to know, have you been asked about medical aid in dying by a patient or a client you work with, or perhaps by a colleague? We're interested to know if this has come up for you so far. We'll give it just another second and then we're going to close the poll. Thank you all. And it looks like we are an even 50-50 for those that have responded, that people have and people have not yet received questions about it. So you're in the right place. So I'm going to start with a few slides doing a very quick review to just kind of lay the foundation for today's conversation before we open it up to our panel for more in-depth conversation. So the Delaware End-of-Life Options Act, you may know, was signed into law last May by the governor, and it did take effect on January 1st of 2026, which made Delaware the 12th U.S. jurisdiction to authorize medical aid in dying. Since then, we actually have had two states. Recently, Illinois joined the authorized jurisdictions, and just within the last few days, New York's law was authorized. Those have not yet taken effect like Delaware's law has, but we now have a total of 14 states that have authorized this option for terminally ill adults. And we do have a number of states that are still considering this in their legislature. And fun fact, there's actually only been 7 states in the entire United States that have never introduced legislation to authorize medical aid in dying. So we know this is something that people are very interested in across the country. Very quickly, we want to provide a brief review of something we discussed on the first webinar in this series, and we will be happy to share that link with you if you want to review. But that is the criteria that must be present in order for a patient to qualify for medical aid in dying within the state of Delaware. And that is that they are an adult over the age of 18 and that they have been diagnosed with a terminal condition, which means that if the disease runs its typical course, they do have a prognosis of 6 months or less to live. They must also have the ability to be making their own medical decisions. This is a request that must be coming directly from the patient themselves. Another person, even somebody named as a durable power of attorney for healthcare, a surrogate decision maker, a family member, cannot request this on behalf of the patient. It must come from the patient, and so they must have capacity to do so at the time of their request. They also must be able to self-ingest and introduce the medications into their GI tract of their own volition. So they have to take a conscious act to ingest those medications. They do also need to prove that they are a resident of Delaware, which can be done by providing, a state-issued ID or card or a driver's license, their tax returns from the previous year, a utility bill, something that shows that they reside within the state. And then there is the multi-step process where two providers confirm that those steps have been met. We're going to talk about that more in a second. And we also want to make it very clear that somebody is not eligible for aid in dying simply due to advanced age, chronic disease, chronic pain, physical disability. They must meet all of these other eligibility criteria. Because care at the end of life must address the physical, emotional, spiritual, and practical needs of patients, their family members, and loved ones, it really must be interdisciplinary care. And this collaborative approach is no different for medical aid in dying. While there can be a tendency to focus most on who's writing the prescription when it comes to medical aid in dying, we know in practice that every member of the team plays a very important role. And that collaboration, in my experience, is key. As a social worker, it wasn't uncommon for me to be the first one to receive a request from a patient or receive questions from the family wanting to know more about what is this End of Life Option Act? What is this option? How does it work? Nurses, of course, are invaluable for coordinating with the physicians, ensuring ongoing management, managing the symptoms, and ongoing assessments. That's critical. And for those that are enrolled in hospice, which years of data from other states tell us that most people who consider medical aid in dying are, I can't say enough about the value and the importance of the hospice team. And so each of these professionals that you see here and more can be a part of the process, whether through physical presence or documentation. And we hope that they are a part of that collaborative interdisciplinary process, depending on, the patient and what their needs and their individual situation are. A reminder that per Delaware's law, the prescribing, or what we refer to as the attending, as well as the consulting provider, must be a physician or an advanced practice registered nurse, so a nurse practitioner. That is part of the requirement. So now let's talk a little bit about the multi-step process itself. I'm going to breeze through this pretty quickly before handing it off to our panelists who will expand more, and we will put this back up on the screen for visual as needed. So this process is very similar in all jurisdictions with some small differences in those who can serve as a prescriber, what role mental health assessments play, and so on. And as the timing also, there are some differences. So in Delaware, the process begins when the patient makes a verbal request to a physician or an APRN. And this attending provider, as they're called, takes the lead in really coordinating the request, or coordinating the care around medical aid in dying. They're responsible for confirming eligibility, completing the paperwork, and overseeing all care. The consulting provider, which is a second physician or APRN, will also meet with the patient to confirm that they meet all eligibility requirements, and to ensure that this is the patient's choice, that there's no undue influence, that this truly is what they want. And if any point in this process, or excuse me, I'm jumping ahead. During this process, the patient will also complete a written request, which is a very specific form that is in the process of being finalized by the state. But this is a written request form that the patient completes to affirm their request. And this document must be witnessed by two eligible individuals. And Delaware, like other states, does have restrictions on who can serve as a witness. It's probably very familiar. If you're familiar with advanced directives, it's going to feel very similar. One of the witnesses cannot be a relative. It shouldn't be somebody who is responsible for delivering their care, anyone who stands to benefit from this person's death, that sort of thing. And then after that first verbal request that the patient has made to the attending provider, there must be a second verbal request. And this is where the timelines and you might have heard about waiting periods. This is one of the places where that comes in, because that second verbal request cannot be any less than 15 days after that first request. And all of this, of course, must be clearly documented in the patient's medical record. And if at any point either the attending or the consulting providers question the patient's ability to make their own decision, this isn't clear to those providers right away, they always reserve the right to request a third evaluation by a mental health provider. In the state of Delaware, like in most states, but not all, in most states, this is a very optional. So it's an as needed, if needed type of a situation. After all of these steps, these required steps have been completed in this process, and as long as the patient wishes to continue, remember the patient reserves the right to stop, withdraw their request at any time for any reason. They don't even have to tell anybody about it. That is part of this being a patient-directed process. Then after 48 hours, after that written request has been completed and all of these steps have been completed, then a prescription can be written. And then the next phase of working with the pharmacist and coordinating the actual medications begins. A very quick highlight that I mentioned required forms a couple of times in that process. There are some very specific paperwork and documentation requirements that are required by the state of Delaware. This chart gives you a brief snapshot of those forms, as well as who must complete them, and then the timeline that they must be submitted after completion. All of those forms, like I said, they are in the process of being finalized by the state. The open public comment period recently closed. They are working very hard to get everything finalized. When the regulations are complete and the forms are finalized, they will all be found on this website, which is there's a new web page that has been built specifically for Delaware's End of Life Options Act. So I know that was a lot of information very quickly. So I am going to open it up to our panel now to talk a little bit more about their experiences. And I'd like to start by asking each of you to just share a little bit about your experience and what it's like for you to have been a part of a patient considering medical aid in dying and receiving that request from them. Who would like to start?
I can start.
Thank you.
Having practiced in Washington, D.C. for about 20 years, I was a current medical director with a hospice organization. The law passed. And shortly thereafter, a lot of questions and inquiries were coming, over the telephone. And initially, I would say that it was a lot more complex and less streamlined than how you've presented it here, Jessica, where, as you said, we are walking advertisement of the waves of healthcare. And sometimes, if we're not equipped with full knowledge and full understanding, it does put us in precarious situations. I was very fortunate to be surrounded by other physicians who experienced medical aid and dying in our Western states. And so they were able to impart a lot of guidance. Um, Sticky situations from the standpoint of what is my role as a medical director of a hospice organization and helping someone who says, I am suffering. And I keep saying, I'm the doctor, I'm here, I'm hospice. Sometimes people need more than hospice. And it's not discounting the hospice, it's saying, give me the access to more because my suffering has gone beyond the quality of my life. And I can no longer continue on this path or trajectory. The first person that I cared for as a consulting provider, because the hospice organization that I worked with remained impartial or neutral, I was able to witness her access of medical aid and dying from beginning to end, her advocacy for herself and for her spouse, and her taking her last breaths in her home, surrounded by her numerous books, windows open, her cats laying by her side, and her husband holding her hand. We were the hospice providers in this case. We were there to help with any untoward symptoms that she may encounter. We did not participate actively at all with her ingestion of the medications. We participated with our heart and with our presence. And she stays with me today, a number of years later. So, what I would say is that my take home has been the reward of walking this journey with someone and families. And it's not necessarily the most traditional way. Being on the receiving end of the resistance, and then also returning that resistance with love and patience and an opportunity to provide further guidance as to what this really is. It's autonomy, it's independence, and it's advocating for someone's quality of life, even while they're facing death. Thank you.
Thank you for
I would
sharing that.
I would love to piggyback on that, Sonja, because as the pharmacist, oftentimes come in towards the end of the process, and how many patients I've met who said, I wish I had heard of this option earlier. Why didn't anybody mention that this was legal in my state? And so I would go back because I was in a system that I had contact with the doctors, and I gave them that feedback. And the response I often got was, I didn't want the patient to think I was giving up on them by mentioning this option. And I just gave them some words. There is a spread of options you will give a patient: investigational drugs, standard of care, palliative care, hospice, medical aid in dying. It just becomes part of the palette that you're offering them without a specific emphasis. And you're really giving them a gift to mention it early, and then they can pursue it if they want, and encourage people to pursue it early, because there is a narrow window towards the end where you might lose capacity. A third of the people, and this is through all the states that have had this law, who end up getting the prescription for the medication don't end up using it. So it doesn't mean that you're going to pursue medical aid in dying for sure, but it gives you a plan B. So do it early if you're even considering it, and then it's there if you need it.
Yeah, those are such great words. I think that what rises to the top of the list for me right now is, first of all, for medical providers, when somebody does mention it or put it on the table, the most important thing to say is something like, "Tell me more." It's to put your listening ears on and make sure, rather than responding out of your own fear or ignorance, or if you're not sure, or if you're worried, it might mean that you're giving up, although those are terrible words, as we know, that it really is about actively engaging in listening, validating the patient's concern, and understanding what's behind this request. What is going on? There are, of course, the specifics about, does this patient qualify, which we've heard the steps about. We want to make sure the patient is really well informed about what their illness is, what their prognosis is, what treatments have they done, how well have they worked, what treatments for the underlying illness might still exist, and what other treatments exist when you can't target the specific illness anymore, but you're treating the whole mind and spirit. And I think a lot of times people express interest in learning about medical aid in dying because they have deep-seated fears or worries about what will happen at the end, but they also have wishes and hopes about how they want to live their life to the fullest and make sure that they don't have a death that is what they consider to be unacceptable. So a lot of that first request is really about listening to the patient, who they are, what are their values. We all know that there are some people who prioritize how long can I live, even if it's a few extra days or minutes. And likewise, on the other end of the rainbow, there are people that say, I'm more concerned about going out strong, about maintaining these particular activities, and these are what's most important. So those kind of things are so important to understand. And then as you uncover what the person's worried about, you can imagine, who on my team can help me with this? Do they have questions about pain, and do I need to call my pharmacist and do some work there? Are they worried about their housing and what's going to happen when they need more help, and I need to get the social worker on speed dial? Are they worried more about the existential threat to their existence and what it really means to be facing a terminal illness and the end of life? And is my chaplain going to be involved? Or more likely, is it everybody? Because everybody has a role to play. And then really reminding the patient that the timeline is in their control. So only they may just want general information, and that's enough for them. They may want to start the process, and that's enough for them. But if they choose to move forward, I want to be responsible for making sure I'm referring them to a consultant, that they've been in touch with hospice, because everybody deserves hospice and should have hospice, whether or not you're going to pursue medical aid in dying. And the tricky part, which is, if for some reason you don't decide to move forward with medical aid in dying, or you lose your window, what is our plan B and our plan C for other things we can do to make sure that you get the kind of death that is meaningful for you? And expect the unexpected, which is sometimes hard for people to hear, and inviting in close friends and family. It may not be in the law who you have to tell, but we know that we best take care of people by inviting in people who have questions and concerns, so we can address them and really focus on our support on the person who's living and dying with a terminal illness.
So beautifully said. Thank you all for sharing those thoughts. And I really want to highlight something you said, Diana, which is really about, it's getting to know the patient and understanding, what's going on for them, what is important to them, what are their values, what does, living life well to the end look like for them. We know that there are a lot of people that have been living for years in pain and lots of discomfort, have been trying to navigate things with a terminal disease. By the time we meet them, they are exhausted. They have accepted that they have gotten to a place, and that is our hope, right? In this work, that we do hope people come to a good, healthy acceptance of what is happening. And we know there are a lot of people that get impatient, and they want to have some control. over the end of their life. They want to be able to, whether that's plan, the manner and the timing, being able to, say goodbye. And so that is such an important part of this process, and really following the patient's lead on that. So, Diana, coming back to you, you talked a little bit about your role as an attending physician. And when you've been in that role, I wonder if you could just talk a little bit more about what that means to serve as an attending, what that looks like, kind of what your thought process is as a physician, and describe that a little more for us.
Yeah, I think I approach it with this humble curiosity that it is both a responsibility to be able to be sure that I am engaging in the practice appropriately, and also an opportunity to really be with somebody at such a tender time. If you think about it, somebody who asks about medical aid in dying is generally someone who has an awareness that death is coming, and we all are going to die, but for many of us, we like to keep it in the background. But here is someone who's really open to it, wants to have some control, and really wants to make the most of it. And so, looking at this chart and following through, my job is to make sure that I get them off to the right start and proceed down these series of steps. Number one, by again making sure that they qualify. Do they have a terminal illness? Is their prognosis in the window where we can start the process? Or might they have a longer prognosis and we might just talk about general information and I can remind them when we can start the process. Those of us that do this work or work with dying patients in general say two things. It's always too early until it's too late. So if someone asks
Mhm.
early, it doesn't mean don't worry, it's not time for that. It means let's talk about this and then let's figure out what we need to talk about first and save
Yeah.
the second thing and pull it out when we need to. So people having accurate information about their illness and about what the future brings. Sometimes people are so frightened by a cancer or their treatment or consumed by the side effects of chemotherapy, they haven't really had a chance to step back from that and say, what is likely to happen in the future? So you want to be sure that the patient is very well informed about what the treatments might offer, how they can help, and also how they might hurt or when they might stop working and it might be time for a different plan. So there's reviewing the medical records and looking at scans and looking through those notes to see what has the patient been told before, what questions have they had, and have they all been answered? And are they really holding a solid understanding of what it means to be in the terminal phase of an illness?
Mhm.
And then very specifically identifying their team, who's going to be the consultant, who is overseeing your hospice care, who is your team, and who do you call when you have questions or concerns? And very specifically, what can you expect that person to help? Sometimes we say you're going to go on hospice and it's all going to be great. It's all going to be taken care of. And it's more than that, right? Hospice has an interdisciplinary team because this is who you ask. If your pain is not under control, you speak to your nurse. If you're having trouble getting in and out of the shower, your LNA is going to be the most important person on your team. So really identifying for people who can help them improve the quality of life so that maybe hastening your death won't be needed, but also being honest about here are the things that might happen in the future that will let us know that we're in a different place.
Yeah.
And sometimes patients are not well informed around that. Now you're feeling good, your energy is strong, your chemo is working, that's fabulous. Now is a good time to talk about what might happen in the future and what hiccups might come and what we're going to do about it if you do get sick or if it does become harder. So all of those things are both really important, but they also are a natural part of a full evaluation from the palliative care perspective about what's going on with this patient, what's most important, and again, looking for specific things that I can intervene on that will improve their quality of life. And then reminding them about the time frame that they will have to see a second independent clinician, talking about when is the right time to come back and see me again. For some patients, they want to schedule that appointment 15 days later because They've determined that. For others, it's thank you for the information, and I'll let you know if I need more. And that's fine also. But being sure they're aware of the timeline and what else needs to happen. And the written request, like anything else, it can be done, but sometimes it requires a little attention. So very clearly laying out the time frame and making sure the person has a good support person. I haven't mentioned up to this point, but I always like to have at least a second set of ears in the room. So when you're talking to a patient, it's really helpful for the patient to have an advocate or a support person with them.
Mhm.
Somebody else who's listening to my information and who can write things down or remember, because even if I say everything beautifully, some things are going to get missed. And that's why we have a second opportunity to revisit the whole process to be sure that all the questions have been answered.
Wonderful. Thank
Yeah.
you. And so, speaking of that second independent clinician that's a part of the process, Sonja, can you talk a little bit about when you have served as the consulting physician and
Mhm.
also how that aligns with your work as a hospice physician?
Right. Thank you. Thank you, Diana, for the warm handoff as the attending provider. The consulting provider works closely with the attending physician. It's another set of eyes, another layer of reviewing the patient's clinical case, their own presentation, and also confirming terminality of disease and the untoward symptoms that is affecting the patient as to why they've come to the point of making these requests. It's very important as the consulting provider to mirror what was received by the attending provider, to fill in any gaps or answer any additional questions that may or may not have been brought up with the initial request. The consulting provider walks hand in hand, step by step, with the attending provider and the patient requesting the medication. It's another opportunity to determine if we need to bring in another clinician to look at the psychosocial components. And so it allows us to practice medicine and also allows us to partner in medicine and in care. What I have found is that as the consulting provider, your role is just as impactful. And the impression that you leave with the patient and their family is important as well, because this is a full experience. As a hospice physician, I lean heavily on palliating symptoms, speaking confidently and confirming terminality of disease and end of life care, and honoring a patient's wishes. Sometimes I would say many of us have felt that end of life care stops with hospice care. But what we've demonstrated is that it goes beyond that. And this is when Sue and Diana have pointed to this, the independence, the autonomy, and the patient's rights and their choices. And so it is important as a hospice provider from an interdisciplinary approach to incorporate a part of someone's care and not take over someone's care. It's patient focused, patient centered, and following the choices that the patient has made and the inquiry that's coming a part of it. I find that having the blanket of hospice helps patients through their process of medical aid in dying, because at any point, if and when their decision changes or is altered, we're always here to continue helping from a quality of life standpoint. In addition, it allows us from a hospice lens to understand and respect the many, many complexities and also the beautiful aspects of end of life care and ways that we can all hold each other and hold the patient collectively. It's not a superiority um, contest. It's all of us involved. Thank you.
Thank you, Sonja. And as a social worker, I can add that, so much of my role has been in serving as that navigator, that coordinator. Sometimes it is helping with the scheduling of those appointments, like you mentioned, Diana. Sometimes it is providing that support along the way, assisting with the anticipation of the death, making sure arrangements are in place. But so much of our work is happening before, during, and after, and just weaving it through. And a lot of that is very similar for the chaplains on the team, the doulas, the care managers. But Susan, your role as a pharmacist is a little unique because you really come in after all that work and all those steps that, Sonia and Diana have described have been complete. So can you talk about, because we really want to emphasize how valuable pharmacists are in this process, and as a part of medical aid in dying. So can you say more about that? And you're on mute, Sue.
Okay, sorry. Thank you for inviting this aspect to the discussion. So there's so much that the pharmacists can participate in and add to the discussion. And what's going to come up is that, well, should every pharmacist know about this, or are you only talking about the compounding pharmacists who are going to be the ones who discuss this with patients? I would love for every pharmacist to understand the basics of medical aid in dying because there's so many old stories out there. Oh, I heard that there's a magic pill. Or I heard that you only have 2 minutes and then it goes, the mixture goes to sludge, and so you have to drink it really fast. And all these things that are old information that, people need to know what the actual process looks like because that's part of their decision making. If they have a clear understanding of what it looks like, they can decide whether that's the route they want to take. Also, the pharmacist, especially the compounding pharmacist, can help guide the physicians with what is the standards of the mixtures. By law, there is not one mixture that is the mixture you have to use in your state. They leave it very open, but there are standards that have come to pass of what are the most effective 5 ingredients, usually in these powder mixtures. What are the best pre-medications that are given an hour before to prepare people to prevent nausea and vomiting without putting the patient into a sleepy mode where they can't have their final wishes at the time they wanted them because some of the pre-medications are sedating. So the pharmacist can have so much participation and guidance for the physicians that are doing this, especially in a new situation where they haven't participated before. And that consultation, I must say, is just so key. Every pharmacist has a different style. Some may just, especially at the beginning, be these are what the drugs do, and this is what will happen. And then as you get more comfortable, it's more of the have people told you what it looks like, minutes into the process, hours into the process, what your loved ones are going to see. It reassures people to know they will fall asleep within a few minutes, that we have means to make it more tolerable, that this powdered medication, which by definition is bitter because it's not a coated tablet, how can we make that more tolerable for you so that's not your last, taste in your mouth? There's so much participation there, in addition to being one of the last people who knows whether the person is still competent or not. There have been scenarios where I've been in the house of a patient and their wife where it was very clear that this person was not aware of what was going on. I could not leave the medication with them in that situation. So did not complete the consultation and said you'll have to discuss this with your prescribing doctor. So we are often the last of the team to do that check, that safety check.
It is such an important role. And I think a lot of the questions that we tend to get, as well as the misconceptions, like you were saying, tend to be around the medications and the role of the pharmacist. So I want to just, repeat a couple of those points. And that is that the medications can only be prepared by a compounding pharmacy because it is a mixture of medications. This isn't just a pill, and this isn't a large quantity of pills that are being crushed or, opened and combined and that sort of a thing. And that there is no law that stipulates what specific medications are being used. And so that goes back to not only the role of the pharmacist, but the importance of the work that the attending provider is doing in determining what is going to be the right medication regimen for that patient based on their body, their disease, as well as the route of self-administration. Oh, so thank you. So before we open it up for more Q&A, so please let us know what questions you have. I want to ask each of you if you can just share a little bit about what are, those top tips. What advice do you have for the clinicians who may be watching this, who are here with us today, or maybe watching this in the future on a recording? What lessons learned, what advice, what best practice do you have to offer around this multi-step request process and supporting a patient through that? Diana, would you like to start?
My top one would just be remember it you have a team and use your team. I think I will say this as a physician because sometimes early in our training we are taught that we're supposed to know it all and be able to do it all. And the longer you practice, the more you realize how it's so much more than that. But in particular with this practice, that it really is about your team, and that I want to encourage people feeling comfortable reaching out to whoever is on your team, whether it's your local hospice doc or somebody nationally or your local pharmacist, that it's okay to have questions, that smart people ask questions, whether it's about, oh, this person is so nauseated, they may want to move forward because they find that symptom intolerable. Maybe our pharmacist has some ideas about a way we can address that. And to really, really feel comfortable asking questions. And even those of us that have been doing this work for a while, we consider it standard to run a case by somebody, to talk somebody through what's happening, to be sure you haven't missed anything, and to see what opportunities there are to always be learning. I'm still learning myself. So that's my biggest piece of advice.
Very good. Sonia?
I second it all. The resources are here. Compassion and Choices is here to walk us through it all as clinicians. It may appear daunting. What I would say is that this is a very, very thoughtful approach and rollout, and we're all here to help each other to care for the patient.
Yes. And Sue?
Uh, I want to reiterate that, mentioning this option is just giving people another tool in their toolkit. So learning about this option early is a gift to your patients to just know something's there, just like palliative care is there if they want it, hospice care is there if they want it. And we do have that ability to give them that gift and just be open to speaking about all the options that they have.
Mhm. And all of that starts with understanding and making sure you understand the facts about medical aid in dying, what that practice looks like, and of course, the law within Delaware. So Sonia mentioned making sure you know about your resources. And so we want to make sure that you know about just a few of the resources that are available to you. We at Compassionate Choices, Sonia, Sue, and Diana all want to be a resource. And I know we are all available to assist with questions. So we invite you to connect with us if there's a situation you'd like to discuss. to please reach out. I'm happy to facilitate connections to any of our panelists as well as others in the community. And we hope you will join us for the next webinar in our series, as well as some of the different resources that we have available specifically tailored for professionals. We have FAQ documents, we have data if you're interested in utilization and the data that we have available around medical aid and dying in other authorized jurisdictions that report in that data. Our Call Compassion is a service where we are here to answer your questions as well as that of your community and your patients. So please reach out to us and do not hesitate to let us know how we can be of assistance to you. I will also say that as you are working on what this looks like in your practice and within your organization, we want to be a resource for that policy development. We have sample policies, and I would love to, explore any collaborations that we might be able to support your work in your community. So please do feel free to reach out to me directly, and I will help where I can, or I will get you connected to the right people. And as we wrap up today, I would love your feedback. We would love to hear from you, what you thought about today's session, what you're hoping we might cover in our next session, what support would be helpful for you, how we can be of assistance. So this QR code will take you to a very short, simple survey that comes directly to our team so that we can hear your feedback. I'm also putting my email address directly in the chat for you, so that if you do want to reach out and there's anything you'd like to discuss, any collaborations we can explore, please feel free to reach out directly. Well, thank you again, Sonja, Sue, and Diana, for being with us, for your time today, for sharing your wisdom, and for sharing your heart, for your patience. Thank you very much to the Compassionate Choices team behind the scenes that supported this. And again, please let us know how we can support you in your work. See you next time. Bye-bye.
Bye, everybody.